Now, the first speaker of the day is Professor Dr. Abdul Rashid bin Abdul Rahman. He is the currently medical director and senior consultant physician at An-Noor Specialist Hospital, Malaysia. He is also head of medical program at Malaysian Institute of Graduate and Higher Training, Kuala Lumpur. I welcome you, sir, on the stage for your presentation.
Ladies and gentlemen, Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Special welcome to the prominent bench there. I've met two of you. Feel very honored that you're here. Thanks for inviting me. This is my second trip to Burban. The last one was in September when I came for the Federation of Islamic Medical Association conference hosted by the Pakistani Islamic Medical Association. I will talk about this topic within the next 30 minutes or so. The burden of diabetes, which you know more than me. The burden of diabetic vasculopathy among South Asian, the neglected diabetic vasculopathy, management of diabetic vasculopathy, and some concluding remarks. This one you know better than me. I saw Professor Basit last night, and he is one of the co-authors. But it's worrying because, these other countries are small islands which are ex-colony. But these are major countries, Pakistan, Kuwait, in Egypt. And if you go down further list, you have Qatar and you have Malaysia, where I come from. Very, very worrying what's happening in our parts of the world. And I'm sure when I heard last night, when you were talking about rollout of your guidelines, it is good to hear that you're going to review your guidelines more frequently. In Malaysia, we review it every 5 years. In America, they do it every year, And I think it's high time that we also have to review our guidelines more frequently to try and see what we can do. Of course, this is a public health problem. Maybe we're not paying enough attention to public health. What COVID tells us is that public health is very important. And maybe one of these is because we have neglected public health and preventive aspect of healthcare. So you have 33 million diabetic in Pakistan. 33 million is the population of Malaysia. So all of Malaysia has diabetes. But up to 28% of them were undiagnosed. And in terms of absolute number, you are not the third biggest number in terms of population, but you're the third biggest numbers in terms of, because of the high prevalence after China and India. And an additional 11 million. So you add that together, you have 40 over million patients with either diabetes or impaired glucose tolerance tests. And many of them, of course, are undetected and not adequately treated. And because of this, they are exposed to serious risk of life-threatening complication. We all know the burden of diabetes. I don't have to tell you that. But let's remind ourselves, leading cause of blindness, leading cause of end-stage renal failure and the need for dialysis, half of all non-traumatic amputation, 2.5 times risk of getting stroke, at least 2 to 4 times risk of getting dying from cardiovascular disease. And in diabetes per se, as you know, the vast majority of them die because of cardiovascular diseases, especially heart attack and stroke. So let's talk a bit more about diabetic vasculopathy. And this is a map of Asia and where people reside in Asia. Georgia and Armenia and Azerbaijan are not strictly Asian. So from Lebanon onwards in West Asia, you can see that the crude rate of death is more than 300 per 100,000. But there is a good spectrum between this country. Then you look at Central Asia, where they are very much close, ethnically speaking, and the crude rate of dying from cardiovascular disease is more than 200 per 100,000. Then we have Eastern Asian, where the crude rate is also mainly more than 200,000. Then we have Southeast Asia, where I come from, and the crude rate is again mainly more than 200 per 100,000, and this is where you are. The crude rate of cardiovascular death from these different parts of the world, and many of them are closer and above 200 per 100,000 population dying from cardiovascular disease. And if you look more closely, there is some interesting pattern. In Southern Asia, more than half are because of IHD, so is Central Asia, but in other parts of the world, and Western Asia, but in other parts of Asia, it is less than half because of ischemic heart disease. And you know, diabetes and risk factors are double jeopardy. So for stroke or hypertension or obesity or overweight, having diabetes actually makes it worse, sometimes double than not having diabetes. And the interaction is strongest with hypertension. And this is where, for example, when we do trials, I was involved in the advanced trial, we look at the interaction between blood pressure and blood sugar in diabetic. And if you look at the relevance of diabetes, and these are studies, cohort studies looking at patients with diabetes versus no diabetes, as mentioned, if you look at the region of the world in Europe, you are exposed to at least twice, and same thing for Australasia, and also same thing for Asia. In other words, the risk of dying, cardiovascular mortality, is at least twice, as we said just now, 2 to at least 4 times. Now, I get invited every year to my country diabetic meeting. Every year they ask me to talk about big vessel disease and hypertension. And I always like to show this provocative slide. I tell them that diabetes is actually a vascular disease with accompanying dysglycemia. And why do I say that? I'm sure you have seen this before many times over in the past. This is very famous at a time when diabetes is labeled as IHD equivalent. We don't hear that much these days anymore. But as you know, vessel disease, especially big vessel disease, occur well before dysglycemia takes place. Same also for microvascular disease. And this was the thing which got me interested. Many years ago, I managed to get some students to do some project with me. And what we did was we measure arterial wave velocity, which is a precursor of atherosclerosis and arteriosclerosis. And this is a painstaking study where we screen so many people to get newly diagnosed type 2 diabetic, newly diagnosed IGT, and normoglycemic. And of course, we have to match them for many things, for age, for height, for this and that. And when we interrogated their blood vessel, we found that even though they are newly diagnosed and they are matched for all other ages, all other variables, they have got increased stiffer artery, increased pulse wave velocity, and with increased augmentation index. And when the augmentation index is increased, this leads to increased central aortic pressure, which is a very, very important endpoint when we treat hypertensive patient. A few years later, the same student collected the offsprings of these people. We managed to get newly diagnosed diabetic and IGT, and then we bring their offspring. Again, we have to match them for everything else. And even in the offsprings, and they are normoglycemic offspring, the blood sugars are normal. You can already show that the offspring has got stiffer artery, increased pulse wave velocity, and also increased augmentation index. And then my student went on to look at another condition, hypertensive. These are offsprings of hypertensive patient, okay? And when we managed to show that even in their offsprings, there is increased systolic pressure, diastolic pressure, and central aortic pressure. So this is what I call preclinical vasculopathy, which you can even show in the offsprings of this patient. Now we came with this hypothesis that the pathogenesis not only include atheroma, but also arterial stiffness. And these are the contributors to all those phenomena. And we mentioned this many years ago, and recently there is a similar publication also highlighting the importance of this vascular damage at the subclinical level, leading to vasculopathy, mainly big vessel and also small vessel disease. So let's look a bit more into the Asian story, the Asian conundrum. Now this is quite a recent publication, and this is in America. South Asian, particularly those from India, Pakistan, Bangladesh, Nepal, and Sri Lankan origin, have a higher proportional mortality rate from ischemic heart disease and cerebral disease, typically earlier in onset when compared to other ethnicity. I have got South Asian root, and that's why I was very interested. Even in the New York Times, it was discussed. Why do South Asians have such high rates of heart disease? And this is an insight into it. Conundrum basically means difficult questions and confusing questions. This is some insight, again, from America, looking at patients of different ethnicity and looking at those with normal weight, because of course weight is an issue. And what they found, if you look at the white population as a reference range, the prevalence of metabolic abnormality is highest with South Asian. More than Chinese, more than African American, and more than Hispanic. And the South Asian cohort, actually, South Asian population came from the Masala study. I'm sure you heard of the Masala study. This is a long cohort study, and it is going into the second generation of South Asian siblings. And next year, they will hopefully release the result of the first cohort study, looking at not only metabolic abnormality, but also vascular measurement, including calcium score in the heart, and also brachial ankle index and internal intima medium thickness. So what are the implications? What are the implications of this observation? Well, the implication is that ethnicity now is an important variable in you prognosticating your patient, certainly in America. So race, ethnicity factor can influence estimation of atherosclerotic cardiovascular disease. Important examples given are South Asian. And this is what happened. A risk calculator now will have to take into consideration the ethnicity of the particular patient. This is, of course, in North America. So is in my part of the world. In Southeast Asia, we have people of Indian origin or South Asian origin, people of Chinese origin. And in Singapore, for example, just like Malaysia, now we tell doctors that when you risk calculate, when you risk predict a patient for vascular disease, don't forget their ethnicity. This is the first page of the Singaporean calculator. Look at that, not just sex, but also ethnicity. And if you are of Indian ethnicity, you add 1 point, +1. So that automatically put you at a higher risk than those of Malay or Chinese ethnicity. So it's now prime time. It is no longer just theory based on observation. It is now used to predict problems for the future of our patient. Now I'm going to talk about vasculopathy in a slightly different light, what I call the glamorous and the forgotten. The glamorous vasculopathy are always the big vessel. That's why, as I'm sure you know, if there is a mega diabetic trial and the trial showed that intervention improved big vessel disease, heart attack, stroke, it is typically presented in cardio meeting, cardiovascular meeting, cardiology meeting. I was involved in the advanced trial, and I remember clearly the BP lowering arm was positive. It was presented at the European Society of Cardiology. The microvascular disease was not very exciting, as you remember, no effect on mortality. It was presented in America at the ADA. So what I call is that the neglected neuropathy, especially neuropathy in terms of diabetic complication. Why is it important? It is important because it is common. This is a Belgian study to show that it is up to 45% if you follow them up. In my part of the world, up to 60% of them, it is a major cause of hospitalization, and it is a major cause of non-traumatic amputation, and it's also a major cause of loss of quality of life in our patient. Very, very important to remember. And it is often misinterpreted by doctors. Yesterday, I liked the lecture when the speaker talked about asking about sleep. We sometimes don't even ask questions whether they can sleep properly or not. Some of them cannot sleep because they have disturbing, painful diabetic neuropathy, which is not picked up. Okay? If not diagnosed early and treated timely, it may progress to neuropathic pain, which is a problem. And this is a publication from a journal called Pharmacoeconomics, because it impacts on not just personal quality of life, but family, societal, and the economic well-being of a particular nation. Therefore, it is very important for us to recognize that and not to miss them in our assessment of our patient. So these are the typical presentation from node neuropathy to slight neuropathy, and it moves up proximally until the patients are then disturbed by the different syndromes of neuropathy, polyneuropathy, mononeuritis, multiplex, plexopathy, and of course the worst case scenario is autonomic neuropathy. And when they develop severe somatic neuropathy, they almost invariably have autonomic neuropathy. Of course, just to remind ourselves, don't forget to check the patient at least at diagnosis and at least once a year, the ankle, the reflexes, and also the 3 modalities. And then we can prognosticate them and then classify them accordingly, whether they've got no neuropathy or they have signs but no symptoms. They've got symptoms but they can still walk properly. They have symptoms severe and they cannot walk properly, or they have disabling diabetic polyneuropathy, particularly autonomic neuropathy. Now, I was at the presentation last night. My understanding is that you are going to have your own guideline adopted from the ADA. I looked at the website last night, and most of your recommendation will come from the ADA. Some you kept, some you removed. that which is not relevant to the healthcare system of Pakistan, you're going to remove, and that which does not reflect the current therapeutic practice in Pakistan, you remove. But this is from ADA, which I believe you also will adopt that. All people with diabetes should be assessed for diabetic peripheral neuropathy starting at diagnosis of type 2 and 5 years after diagnosing type 1, and then at least annually. The challenge in many doctors' practice is to remind them it is time for yearly checkup, time for yearly blood tests, time for yearly assessment of neuropathy. Assessment of distal symmetric polyneuropathy should include history taking, assessment of small fiber and also big fiber, and then after that you try to, of course, classify your patient's neuropathy. Symptom and sign of autonomic neuropathy, which is very, very disturbing, especially if they develop cardiovascular autonomic neuropathy, that actually will impact on their mortality, on their survival, sorry. So make sure we don't miss it. Same principle for type 2 at diagnosis and 5 years for type 1 after diagnosis, and then do it yearly. So this is very, very important. This is a very important recommendation which we should remind our doctors to do it. Another aspect I want to quickly remind to you is the issue of vitamin B12 deficiency and neuropathy. This has been known for many years, but it hasn't taken center stage in terms of treatment recommendation. Studies from Pakistan showed clearly that it is not uncommon, 30%. There was another study from Karachi, a more recent study, to show that it is not uncommon. So do not miss it. These are studies from Thailand. And these are studies to show that it is a problem and you have to look for it. And if it's there, it should be ruled out before treating diabetic neuropathy, and deficiency does not develop if dietary intake of vitamin B12 is adequate or prophylactic supplementation is given to this patient. Another phenomenon which we tend to forget is it can be associated with metformin usage. Again, something which we know for many years, but it hasn't taken center stage in our treatment of our patient. Reduced B12 occur in up to 30% of patients taking long-term metformin. B12 levels should be monitored in patients on chronic metformin therapy, although some studies show that you can demonstrate it as early as 6 months of therapy. If the deficiency is detected, metformin can still be continued. As you know, it is a very important drug in terms of prognostication and improvement of big vessel disease. And there is a study, and this is very reassuring. There's a study from Greece, and the investigator also include my alma mater in Sheffield. And the study showed that 1,000 microgram a day significantly improved nerve function and clinical symptom in diabetes with peripheral neuropathy on metformin. I really like this study because they try to control for confounders, including glycemic control. It was well controlled, and in this study, they interrogated the blood vessels, the nerves, symptom-wise, and also by electrophysiology and all possible modality, including assessment of autonomic nervous function. So very, very reassuring, and I'm sure there will be a very big trial coming up soon looking at this. This is the problem, you see. People do not want to invest in mega trials on small vessel disease, especially neuropathy, because the money is not there. All the money are on all the new drugs looking at big vessel disease. We need somebody to be brave enough to invest in this kind of study looking at neuropathy. Very quickly, management of diabetic vasculopathy. What I'm going to do is just summarize what the current guideline says. This is the American Endocrinologist Association, which released it a few days ago. Number one, it mentioned about the importance for primary prevention of maintaining proper weight, or rather adequate weight. And there is a statement in the guideline. In South Asian, even 23 to 25 BMI is considered as overweight. And glycemic control, keep it to below 6.5%. Blood pressure below 130/80. This is an American suggestion for all blood pressure, which most part of the world do not actually agree to this. And lipid control, LDL, to below 2.6 millimole per liter as a primary prevention against vascular disease, diabetic atherosclerotic vascular disease. Secondary prevention, again from the same guideline, you can be a bit more liberal in terms of glycemic control. Anything below 8 is good enough, and particularly thinking about potential silent hypoglycemia. Blood pressure is still the same. American recommendation for blood pressure is very simple. Anything above 130/80, treat, and target is below 130/80. Very simple recommendation. But in terms of lipid control, LDL is below 1.8, but for the very high risk, especially those with recurrent event, try to bring it to below 1.4, and you will listen to a lecture after this on lipid lowering. Now, as far as neuropathy is concerned, none of the guidelines say anything major about this. For example, painful diabetic neuropathy is a problem. Patient cannot sleep and they have poor quality of life. But what we should try to achieve is a reduction in pain score by at least 30%. But some therapeutic agent can bring it even better, even more than 50%. That should be part of our repertoire when we treat our patient. Do not forget to ask for it, to look for it, and to intervene as appropriate. But we have a statement from the American Diabetic Association to say that gabapentinoid, especially pregabalin and also gabapentin, SNRI inhibitors, TCA, tricyclate, and sodium channel blockers are recommended, and they are given Class A recommendation. However, if you look very closely at this recommendation, you cannot put all of them at the same level. These are the European recommendation from the Neurological Society. These are the American recommendation. In terms of the top two, first liner, they gave Class A recommendation for pregabalin and Class A for the European Society, but the American Society gives Class B recommendation for painful diabetic neuropathy. Now, I'm a bit rushing because every time I got to give a talk, there's a speaker after me, I get a bit nervous. Some concluding remarks. Diabetic vasculopathy is the prime cause of morbidity and mortality among diabetics. No question about that, no debate. No debate about that, okay? Especially over the last 2 decades. In fact, I used to make a joke to our diabetologists, you people keep looking at people's sugar when they drop dead from heart attack and stroke. So do something, okay? But things have changed since. South Asian ethnicity has higher predisposition and worse prognosis to getting diabetic vasculopathy. Unfortunately so. Why? Studies are still ongoing, but we have an idea. Among other things, the clustering of risk factor, which is more intense among South Asian ethnic group. And this seems to remain true even though they migrate to America, and this is being studied further. While big vessel disease is routinely assessed, microvascular disease, especially neuropathy, tends to be overlooked and neglected, unfortunately. Management of diabetic macrovascular disease is well established. Very clear targets, very clear therapeutic intervention, very clear, and lots of money invested by the industry. However, the same cannot be said for microvascular disease. Very sad, okay? So if there is no big sponsors from mega industry, I suggest society, even government, look into this more seriously, especially in a country like Pakistan where the prevalence is high and when the problem statement is clearly there. Vitamin B12 supplementation must be strongly considered in symptomatic patients and or those on chronic metformin therapy. Do not miss the elephant in the room. We heard about that yesterday, okay? And pregabalin is a preferred treatment for painful diabetic neuropathy, and that has been shown by many studies and meta-analysis. I think I will stop there with 7 minutes to spare. Assalamualaikum warahmatullahi wabarakatuh. Oh, wait, sorry. I got 7 minutes. I just want to make some advertisement. You go back to the slide, please? Can you go back to... I'm the president of this society. It's called the Federation of Islamic Medical Association. We now have 43 countries, from Canada to Australia, and Pakistan is a very important, one of the founding members of the society. Every year we have a scientific meeting, and this year I will host the meeting, and we will focus on non-communicable disease in the Muslim world, which is very worrying, and we will focus a bit more on diabetes. So mark the place. It's in Putrajaya, our administrative capital, which is modeled on Islamabad, and this is the date for the scientific meeting. Do come, and we'll continue discussing about why are we having problem with non-communicable disease, especially diabetes. Thank you very much.